What is ankle arthritis?
Simply put, ankle arthritis is very similar to hip and knee arthritis in that it's just a loss of cartilage. Cartilage is supposed to cushion our ankle. As that wears down, we start to get pain, swelling, not so much inflammation, but just a lot of fluid. The difference between ankle arthritis, most people don't get it unless you've had an ankle fracture or some kind of instability or trauma. The vast majority of ankle arthritis is post-traumatic, almost 80%. So if someone out there is listening and they had an ankle fracture 15 or 20 years ago, they're starting to get stiff, they're starting to get swelling and pain, chances are it's early arthritis versus the hip and knee that's just kind of old age and kind of happens to all of us over time.
Your questions in through Facebook Live on Wednesdays by 5 p.m. You can find more information about the show on our Facebook, Instagram, Twitter, YouTube, and our website, doctalklive.com. That's DOCTALK live.com. Also, listen to our podcasts on Spotify, iTunes, and iHeartRadio. My name is Dr. Paul Cespedes, and I'm hosting today's show. Did you know that 25% of all bones in the human body are in your feet? When these bones are unaligned, it throws off the alignment for the rest of your body too. In today's show, we'll be discussing foot injuries and pain, specifically ankle arthritis and flat feet. Today we have Dr. Calvin Rushing with us. He is fellowship-trained podiatric surgeon, and he is here from the Dallas Orthopedic and Shoulder Institute. Dr. Rushing, welcome to Doc Talk Live. Thank you very much for volunteering your time. Please tell us a little bit about yourself.
Yeah, first off, Paul, thank you for having me here to Doc Talk Live. It's a great opportunity. I really appreciate it. Yeah. I'm a native Texan. I was born from San Antonio originally. I trained. I did general podiatry residency with some reconstructive surgery in South Florida. After that, I was really fortunate to get the spot in fellowship at the Orthopedic Foot and Ankle Center, which is the only orthopedic foot and ankle fellowship that trains podiatrists side by side with our orthopedic colleagues. And then afterwards, I was fortunate enough to kind of run into a great group here in Dallas, in Sunnyvale. So now I practice out there. I've been in practice just over a year, so still very green. But again, love the community, love the area. Dallas has already grown on me.
Good.
And I do go back and forth every weekend to see my 1-year-old son, Landon, who's in San Antonio.
Oh, that's fantastic.
So a lot of travel, but native Texan happy to be home.
Good. All right. Well, welcome. All right, so let's get started. And first off, just can you kind of explain what is podiatric surgery?
Yep, so in general, podiatric surgery is kind of the specialized treatment of, I guess, any ailment of the foot and ankle. I think, podiatry in general focuses more heavily on the forefoot and the midfoot, whereas our orthopedic colleagues focus more on the ankle and the rear foot. And so kind of, the interesting with my training is that I got both the podiatry training with the focus and the emphasis on the forefoot and the midfoot, and I turned around and did a really intensive reconstructive fellowship focusing on mostly ankle and rear foot. So I kind of see the gaps in both training, and it's an interesting blend when you put it together.
I honestly never knew that was the difference between the two, just like kind of the midfoot and it's one or the other. I just figured it was the whole foot for podiatry. That's interesting. All right, so, on a daily basis, like I go home, my feet hurt. Do I need to come see you as a podiatrist?
Generally, no. I think all of us go home, all of our feet hurt at the end of the day for one reason or another.
Sure.
I think most of us can, just, protection, rest, ice, elevation. Most of us just need to get off of our feet. If you're a runner, there are a lot of runners out there. I'm sure there are runners who are listening to this show. You run, it takes anywhere between 2 and 6 days for your arch to recover after you've done an hour-long run.
Oh, wow.
So sometimes we just need to get off our feet and give ourselves rest. If not, then usually our primary care colleagues or our nurse practitioners, PAs, typically the things they can give you can save you a trip to, seeing someone like me. So typically, no, you don't need to see me.
So then how would I know that the pain is bad enough that I need to come see you?
Typically, most of the people I've seen have kind of gone through at least 3 to 6 months of conservative treatment. Primary care, physical therapy. Someone's already been kind of going through everything that we usually typically go through. And after about 3 to 6 months, patients at that time is kind of frustrated.
Yeah.
And whatnot, and so then that after 3 to 6 months of failed concerted treatment, no improvement. I always tell people when they come to see me, if you don't have at least 50% improvement in 4 weeks, something's not working.
Okay.
So typically, if you've gone down that path of primary care already, PAs, nurse practitioners, physical therapists, then I'd say, come see me and see if we can't get you at least 50% better in 4 weeks.
Okay. All right. Good. And then, you talked a little bit about the podiatry versus orthopedic surgery, forefoot and the as opposed to like the ankle and all that. Anything else as far as like any other major differences between whether or not to go see orthopedic versus podiatry for a foot issue?
Yeah, I think a lot of it comes down to spine. Not a lot of people do foot and ankle and orthopedics in general. It goes unmatched every year, multiple programs.
Wow.
And so I think that, and there are great orthopedic fellowships, and there are not great orthopedic fellowships, just like there are good podiatry residencies and not good.
Sure.
So I think that as long as the patients do their research, talk to their friends and family, word of mouth is huge.
Yeah.
If you have somebody who's had great success, and typically I say word of mouth, do your own research, and then when you go and you see somebody, you kind of get a feel the first time you're with them whether or not you feel comfortable with them.
Yeah.
And just kind of research in general shows us that it's important to have that kind of relationship with your patient. So if the patient doesn't feel comfortable with the provider, it will affect the outcome whether surgical or not.
Sure. Yeah, that's very true. All right, folks, you are listening to Doc Talk Live, and we are here with Dr. Rushing from the Dallas Orthopedic and Shoulder Institute, and we are discussing ankle arthritis and foot pain. Okay, so let's talk. What is ankle arthritis?
Simply put, ankle arthritis is very similar to hip and knee arthritis in that it's just a loss of cartilage. Cartilage is supposed to cushion our ankle. As that wears down, we start to get pain, swelling, not so much inflammation, but just a lot of fluid.
Okay.
The difference between ankle arthritis, most people don't get it unless you've had an ankle fracture or some kind of instability or trauma.
Okay.
The vast majority of ankle arthritis is post-traumatic, almost 80%. So if someone out there is listening and they had an ankle fracture 15 or 20 years ago, they're starting to get stiff, they're starting to get swelling and pain, chances are it's early arthritis.
Okay.
Versus the hip and knee that's just kind of old age and kind of happens to all of us over time.
Okay. So let's say you're concerned that it might be ankle arthritis. Is there any test you do, imaging, something that would be like, oh yeah, that's it?
Usually just plain radiographs.
Really? Just X-ray?
Plain radiographs, clinical assessment is usually enough. Kind of straightforward stuff, and then just kind of there's a lot of treatment of ankle arthritis is a really broad spectrum. So it just depends on how early you catch it.
Okay. Now, what about we were talking about runners earlier? Do you see a lot of this in runners, and biking's a big thing too? Do you see a lot of this in with repetitive motion type stuff? Do you see ankle arthritis in that population?
Most of the ankle arthritis is one of two populations. Either somebody had ankle trauma 10, 15 years ago. Okay. It was fixed great, and just over time, they've still developed arthritis for a number of reasons. Yeah. Or the second one is unfortunately somebody had trauma. It was fixed, it was malreduced, or something wasn't done right. Okay. And they develop arthritis within a year or two after surgery.
Oh, wow.
So it's kind of one or two. One is kind of older, the 50, 60, 70-year-old. Sure. The second population is usually, unfortunately, the 25 or 30-year-old.
Okay. So it doesn't sound like there's really a good strategy for prevention other than you try not to break your ankle.
Exactly.
Okay. All right. Exactly. Good. All right. Easy enough. So, and then you said swelling and pain are the most common things. Now, is it massive swelling, where you can't get your shoe on type of thing, or is it more subtle than that?
Typically, it starts off pretty subtle. The downside of the ankle is that, again, it's under the knee. Underneath the ankle, there's more joints. There's a lot of joints in the foot. Yeah. As soon as you throw off someone's gait, the ankle throws off. It's not just ankle arthritis and ankle pain. It'll throw off their contralateral, the other knee and hip. Yeah. It really starts to mess with people. If they have hip arthritis on the other side, they start to become more symptomatic because of that. Huh. You have patients that will come in that have severe ankle arthritis, they want it fixed.
Right.
And it's kind of a difficult conversation to let them know that we've got to fix the hip and the knee first before we can go down to the ankle. Otherwise, it's not going to work out.
Yeah. Okay.
So it throws off your entire alignment.
Right. Yeah. I remember at school they always said whichever joint hurts, you got to look at the one above and below too. Right? So I get that goes along with that perfectly. All right. Good. So what kind of, you were saying you got to treat the other side. If you're having issues on the other side, you got to treat that before you can treat the ankle arthritis. What other treatments are there for the ankle arthritis short of surgery? What can we do to help with that pain?
Usually, again, I have this conversation with everybody who comes in.
Sure.
Ankle arthritis, it's a degenerative process. It's going to continue to happen over time, just like the hip and knee. We talk about injections, but every time we give an injection, it's just like if you do an injection in the back, injection in any joint, we're going to lose some cartilage.
Yeah.
We're masking symptoms. We're not actually treating the problem. Typically anti-inflammatories, Tylenol. We can do Arizona bracing. There are braces that can give people a long-term relief and stop them from having surgery. The issue is that people want to also be in comfortable shoe wear, and the braces can be very constrictive. They're kind of bulky. They're not exactly appealing to look at.
Yeah.
So the women in general typically don't like those very rigid leather gauntlet braces.
Sure. Yeah.
Which in a lot of times can prevent surgery. A lot of times they'd rather undergo surgery than have to wear that for 10 or 15 years.
Okay. And so let's say they do get to the point of surgery. What kind of recovery are you talking about? And I guess maybe even before that, when you say surgery, are you talking about like a whole ankle replacement? Or I honestly don't even know. I've never seen like an ankle replacement surgery. So what would that be? What kind of surgery?
So if you catch it early, I've seen everything from catching ankle arthritis early in someone who's 33 years old, where you go in, you just clean out the ankle. You just take down some spurs, you clean out. You can try and help stimulate cartilage to regrow.
Yeah.
If it's early on enough and prevent the progression.
Yeah.
If it's late enough, you start talking about fusing the ankle, replacing the ankle. And that's kind of come a long way. 10, 20 years ago, no one was replacing ankles. They didn't hold up. A lot of it came down to the fact that, again, foot and ankle has been kind of the red scarlet in orthopedics.
Yeah.
Not a lot of attention and research had been done.
Yeah.
In the last 10 years, there's been a big boom. So there's been a lot of research, and we're really understanding that it's the joints underneath the ankle. The foot alignment is affecting the balance of the ankle. And so there's the survivorship overall. People who are getting total ankle replacements now at 10 years, survivorship's 90%.
Oh, wow.
Which is not as high as hip and knee, but we're getting there.
Yeah.
We're getting there.
Yeah, because, it's not like a ball and socket.
Right.
It's a very complicated joint. Yeah, interesting. And then, so say you have to go all in, ankle replacement, what kind of recovery time is that?
So if someone does an ankle replacement, so I would say if anyone's young, they're a contractor, they're active, sometimes it's better just to fuse your ankle. That way you're not worried about, the ankle failing long term. In 30 years to come back, take it down to replacement. Ankle replacements, the recovery is extremely fast. It's almost as fast as a bunion. So someone can walk the next day, assuming they had no other concurrent procedures done.
Yeah.
If they had other things done, which typically we do have to do, they typically have to stay off of it for about 10 days.
Okay.
They start walking at about 2 weeks in a boot.
Yeah.
Sutures come out between 2 and 3 weeks, and they're back in normal shoes between 4 and 6 weeks. So the actual recovery period is pretty quick after an ankle replacement.
Yeah.
Versus an ankle fusion where they're off of it for 8 to 12 weeks, and it's quite prolonged in comparison.
Yeah. Okay. All right, folks, you are listening to Doc Talk Live. We're here in the studio discussing ankle arthritis and flat feet with Dr. Calvin Rushing from the Dallas Orthopedic and Shoulder Institute. I never asked you, do you have a website?
I know it's a mouthful to say.
Yeah.
So the website is www.theshouldermotion.com.
Okay.
It's not just myself. We got to have a great team there. Dr. Jeff Zhao is kind of the shoulder and elbow reconstructive surgeon. Dr. Reed Bartz is kind of the sports reconstructive guy.
Yeah.
And we also have Nicole Scotch there, and then also PT attached.
Awesome.
So it's kind of, we do
Full service.
everything but spine.
Okay.
But we know a lot of good spine surgeons that we can refer to.
All right, good. Okay, so now let's change gears. Let's talk about flat feet. Right, we've all heard about it. what exactly does it mean when somebody is told they have flat feet?
So long story short, we all start off with flat feet, and as children, progressively our arches are supposed to kind of come into a more upright position. Sometimes for a number of factors, they can vary. Those arches start to flatten out over time. It can be traumatic. So a lot of soccer players will have traumatic flat feet after a rupture of a tendon or a ligament. More commonly, it's just old age, weight, time, gravity. All those things kind of take their toll and cause us to kind of collapse inward and outward. And so that's kind of just a natural thing that happens over time for most of us. Most people have flat feet.
Interesting. So then what symptoms or what other kind of challenges would somebody with flat feet face where they're like, oh, it's probably my flat feet?
A lot of it just comes to starts off as arch pain. So when my flat feet became symptomatic, it was arch pain that just drove me absolutely crazy. I kind of have an afterburn in my feet when I was trying to, lay down in bed. And so that's when I actually started about 3 years ago wearing custom orthotics. My feet are flexible. They're flexible flat feet. I have had 0 foot pain since. No plantar fasciitis. Sometimes people will manifest with plantar fasciitis, heel pain. Sometimes they start to get Achilles pain because of the flat feet. The flat feet will make bunions worse. They'll actually make the progression of bunions and hammer toes happen a little bit quicker. So once the flat feet go, it's kind of everything starts to kind of go around it too.
All right. Good to know. And so is there any way to prevent this?
So easiest prevention is when you get to the point where I was at, where you already have a flexible flat foot, just to get into an orthotic that corrects the arch and prevents you from collapsing further. If you do that and you hold that position, you're not going to develop arthritis. So if you don't do that and you just let it fly, a lot of people in their 50s and 60s will start to develop arthritis. The tendons will start to tear and attenuate. They'll get really weak. I have a neighbor who can't even exercise anymore because of the flat feet are so severe, and he's late 30s. So again, it progresses differently in all of us, but at the end of the day, if you don't do something, whether it's over-the-counter orthotics, custom orthotics, you're looking at arthritis down the road.
So basically, the sooner the better that you recognize it and start treating it, the better the outcome. Okay, good. And then just because I'm having that pain, should I come see you necessarily? Like, hey, I think I have flat feet. What can you do to help me? Is that like, what do I do if I think I have flat feet? Should I call your office?
Most of the time, if most of our primary care colleagues, they do a really good job with kind of heel pain, Achilles issues, bunions, stuff like that. If you tell them you have flat feet, most of the time they send you right over to us. So typically it's something that's a quick referral over, and we'll have that discussion of if the investment in custom orthotics is worth it for you. What the kind of stage is your flat foot at? Is it really your flat foot? Is it something else? And sometimes it's other things. Sometimes it's stress fractures or other things that are going on. But usually that's a quick referral to us.
So and then I guess once like say I get referred to you, so what? And I'm sitting in your office, and so how do you diagnose, and then what's your first step in treatment? Like, am I going to have to go get x-rays and do things like that, MRI, anything?
So typically x-rays, just when you come in, I like to go over x-rays with everyone. I'm all about patient education. Whenever I'm talking to patients, I want them to kind of understand what they have, why they have it, and then treatment options. I'm never it's very rare that there's ever only one right decision in treatment. With flat feet, at least, there's a lot of different things we can do. And so I like to kind of have that shared decision making with the patient. So x-rays, first off. Afterwards, I'll sit there. Usually they come in with husband, wife, brother, sister, significant other. So we kind of go through some clinical tests and explain to them the flat foot, let their significant others see that, explain the pathology to both of them at the same time. So usually it's just x-rays, clinical assessment, and then kind of answering questions and telling them where they're probably hurting at. And usually you start pointing to 3 or 4 different places, and they say that's exactly where it hurts. Right there.
All right. Okay, good. And then we talked about custom orthotics, things like that. Are there any other corrective procedures that you can do? Like, would you ever need surgery for that to correct flat feet? Like, let's say maybe I let it go on a couple of years too long.
That's always an option. Whenever we can avoid surgery, we try and do that.
Yeah.
But sometimes we do get to a point where, for whatever reason, we do need to do surgery for a flat foot.
Huh.
It's obviously easier to do it sooner rather than later.
Yeah.
We all heal slower as we get older.
Right.
Our soft tissue, sometimes skin doesn't heal quite as fast.
Right.
Need more time off. But again, usually if you catch it early enough, you can avoid surgery. But at the end of the day, sometimes surgery is needed.
Okay. And then let's say I did need surgery. What kind of recovery process would that look like?
If you have, depends on kind of what stage your flat foot is. If it's flexible like mine or custom orthotics just weren't working for me anymore, much faster recovery than if you're talking about somebody who's in their late 70s with a lot of arthritis.
Okay.
So it really just kind of depends on what's being done to correct that flat foot.
Yeah.
There's like over 100 procedures that have been described, so it kind of depends on what's being done.
Really?
Yeah.
Wow.
Yeah.
Just for flat feet.
I think a lot of people wanted procedures named after themselves. Is probably what it was.
That's funny. Yeah, I had no idea. Okay, and then let's say I do come to you early enough with the flat foot, and I get the custom. How quickly would I expect to see improvement if I got into the custom orthotics?
I usually tell people it's kind of a gradual break-in period. They're like glasses. So the orthotics only work when you're using them, just like glasses only work when you're wearing them.
Okay.
I always tell people, first 7 days, 1 hour day 1, 2 hours day 2, 3 hours day 3.
Okay.
Your arch is used to collapsing.
Yeah.
And so it's gonna have to accommodate a little bit to being elevated up.
Yeah.
So it's usually about a week or two to kind of accommodate in. And then after that, usually by week 3 or 4, patients start to notice relief.
Okay. And I guess, we keep talking about custom orthotics. Maybe people don't even know what that means. Is that like a special shoe that gets made for me? Is it an insert? Will it fit in anything? Do I have to wear it if I'm like playing tennis?
So, long story short, so there are a lot of orthotics out there. Patients and I always have this conversation.
Yeah.
A lot of them, I call them money grabs. That they're not actually doing much. It's just kind of somebody trying to make. Unfortunately, It's the business of medicine.
Yeah.
But what I tell people is custom orthotics, the way they should be made, are actually designed specifically to that person's foot. So how many degrees of correction do you need to actually just have a normal arch without overcorrecting you?
Okay.
They should be thin enough where you can fit them into a running shoe, but also a dress shoe. It's custom orthotics, if they're done right, can go into any shoe and be comfortable.
Yeah.
The downside is that a lot of times the time and the attention to that custom orthotic isn't necessarily put in, and so patients get an orthotic that only fit in one pair of shoes and they end up not using it. It's just a waste of money.
Yeah. Okay, I didn't actually know all that. So how do you actually determine like the degrees? Like do you have like a special machine to like measure your foot and what? Do you?
It's actually, and everything is kind of automated with a scanner and a computer. Yeah, so it actually calculates exactly the degrees the person needs to be corrected, and you can actually play with a 3D image and see what the person's foot would look like, and if you tweak it a little bit more, a little bit less.
That's pretty cool. I had no idea. Because I didn't know that much went into making an orthotic, right? I'm so used to just seeing like Dr. Scholl's or whatever, right? I'm assuming that's an orthotic, right?
Yes.
The doctor. Okay, because you see those all the time, like at the drugstore. Okay, that's interesting. So like even for the ladies out there, like let's say they want to go out, they can still, if it's a good orthotic, they can still get it into their nice shoes and still be comfortable, hopefully.
Heels? No.
Okay.
No. So if you go about a 3-inch heel, some of the 3-inch heels you might be able to get a really low profile.
Okay.
The toe box becomes really narrow though, so your toes get really scrunched.
Okay.
So it's usually the toe box.
I'm just thinking my wife would want to know this question. It's not for me.
So usually the heels are no for the women, but everything else, yes.
Okay. All right, cool. Yeah, I didn't know that much went into an orthotic, to be honest.
Probably way too much.
No, it's actually interesting. I was just interested when you mentioned it. Okay, so we're actually, we got about a minute left, so we're getting to the end of the episode. Do you have any final comments or advice for our listeners, about when to come see, get help for their foot and ankle pain?
I think my advice would just be kind of listen to your body. All of us, we pay so much attention to our teeth, our face, our hands, hips, shoulders, back, and we live with foot pain and ankle pain for 5, 10, 15 years.
Yeah.
So I would say a lot of times if you can catch stuff early and you just listen to your feet, you'd be surprised how many issues and problems you can avoid down the road.
All right, good advice. Thanks again, Dr. Rushing, for coming on to the show. We really appreciate you volunteering your time. This is Dr. Paul Cespedes with Doc Talk Live signing off. Stay healthy.